case, a 1 year, 2-month-old female child, sir, hailing from
Put up full screen. Put up full screen.
My screen.
Okay, doesn't matter. Okay, go ahead.
Yes. 1 year, 2-month-old female child, sir, hailing from rural Bengaluru, a second-born child to a non-consanguineously married couple with married life of 6 years, which came chief complaints of delayed attainment of milestone as noticed by the mother at 6 months of age. Since there is a developmental delay, would like to analyze the history from the antenatal periods.
Just 1 minute at this point of time.
Yes, sir.
I want you to justify your
sir.
statement that you want to start with the right from birth or antenatal period. Why have you to do that? The story starts at 6 months of age.
Yes, since the developmental delays, the cause of developmental delays could be antenatal, natal, or postnatal causes are one of the significant factors for example, developmental delays.
Yeah. For example, you can have something that happened a week ago.
Yes, sir.
Okay, or
yes,
a month ago, or
yes,
3
sir.
months ago. Why do you have to say that you go back to antenatal period? You justify that statement.
Yes, the cause of developmental delays, sir. Notice because the cause of developmental delays usually is antenatal, natal, postnatal, or any event which has been a significant in the eventful.
No, that is fine. Then I agree that. But
yes,
what made you ask for an antenatal history first? Okay. Why don't you think that at 3 months of age there must have been some insult which has left behind the developmental delay? You get my point?
Yes, sir. Yes, sir.
So what I want to strive at is every time you have a developmental delay,
yes, sir.
Students don't go back to antenatal period, but
yes, sir.
I want you to justify that. And how do you justify that? You would say that the parent noticed delayed developmental delay at 6 months of age. However, on direct questioning, there was no obvious postnatal insult.
Okay, sir. Okay,
and therefore, I want to go back to antenatal history.
Okay, sir. Okay, sir.
Okay, that's important because
sir.
For all that you know, at 2 months of age, if the child had a meningitis, he is left behind with developmental delay.
Yes, sir. Yes, sir.
You get the point. So
yes, sir. Sure,
make that clear to the examiner that you have asked for no postnatal insult. All right. Go ahead.
Okay. Okay. Thank you, sir. We have met since starting from the antenatal history. Mother is 24-year-old, sir, married at 18 years, married life of 6 years, the first child being alive and healthy, of pre-pregnancy weight of 48 kgs and weight gain during pregnancy of 6 kgs. Height is 150 centimeter with BMI of 20.3, sir, with educational qualification of 12 standards. Paternal history, 26-year-old father, whose education qualification 10 standards. By this, mother, first child she had, it was a teenage pregnancy, sir. First when she had, and weight gain during pregnancy is inadequate, sir. Usually 12 kgs, that is significant in this part of the slides. And there is an adequate gap between the first child and the second child.
Okay, go ahead.
Yes, first trimester. She booked case at a PHC, conceived spontaneously. Spontaneously conceived, diagnosed by UPT at 2 months of pregnancy. First trimester scan done at 3 months was told to be normal. Folic acid tablets were taken in first trimester, but not preconceptionally. No history of fever with fever with rash, drug intake, radiation exposure. No lymphadenopathy in the neck, preauricular or postauricular region, or any excessive vomiting. No history of any hypothyroidism, type 2 diabetes mellitus, or hypertension, or any other illnesses in the mothers. So shall I continue?
Yeah, please.
Yes, second trimester history. Quickening felt at 6 months. During the first pregnancy, quickening was felt at 5 months. And there was decreased appreciation of fetal movements as compared to the first child. And TT doses were taken at 4th month and the 6th month. Iron and calcium tablets taken at 5.5 months of gestation. And there was anomaly scan was done, which showed minimal collection of fluid in the brain in the mother's words.
Fine. At this point of time, what do you make out of this diminished fetal movement sensation? What does that mean to you?
Yes, sir. Decreased fetal movements, that is one of the there has been neuromuscular causes to be ruled out. Neuromuscular causes like any myopathies, dystrophies, or any per se any cause for decreased fetal movements. One is CNS cause to be ruled out, sir, and other is neuromuscular cause to be.
Do you think myopathy or dystrophy starts antenatally with diminished fetal movements? You must have seen Duchenne muscular dystrophy, which is often diagnosed after child starts standing, walking, etc. Till then, everybody feels the child is all right. So what makes you feel that that could be picked up even antenatally by fetal movements? So point is, decreased fetal movements could mean paralysis or paresis. And that could possibly suggest a spinal muscular atrophy more than any other. And you know that spinal muscular atrophy can start antenatally or very early in infancy or also very late thereafter. So that is fine. So on this second trimester scan, you started feeling that there could be some neuromuscular problem in this child. But what do you make out of mother saying that there is extra fluid in the brain? That is not neuromuscular.
Yes, sir. Any CNS cause or any CNS cause or CNS plus leading to peripheral decreased fetal movements.
Very good. So you are right in interpretation. I want to drive a good attention to this finding. Now you said that the first baby, the mother had feeling that at 5 months he could see the movements of the fetus. But on this, it could be 6 months. Now, these 5 and 6 months does not make any difference. Because you can imagine how close each other they are. And for all that you know, it's a mother's perception. But for a doctor, it may not mean anything very different. So we can leave that alone for a while. Now, when you are talking about the mother reporting some extra collection of fluid, also take a note that whatever the reports you have or what mother has been told, it also may not be necessarily correct. Because the person who interprets the all these tests have to be an expert to know correctly. And it is not rare to find antenatal malformation in an anomaly scan, but postnatally, you find that there is nothing wrong with that child. So the message is you sound the parent to say that this could be transient, this may not last, but we will see after birth what it is. So you don't start frightening the mother to say, oh, you have a hydrocephalus. It may be or it may not be. Right? So learn not to opine on these reports straight off unless there is something tremendously wrong. I'll give you an example. I would see an antenatal scan which says that there is an agenesis of corpus callosum. But the point is that corpus callosum may not be already there in the first, second trimester or even sometime early third trimester. When the baby is born, there is nothing like agenesis. So sometimes there could be a misinterpretation of these findings. So we must be aware that these are not the facts that we can bank upon, but we are certainly, our antenna goes up and say, oh, I have some problem in this side. Good. Go ahead.
Third trimester, there's no history of GDM, so hypertension, premature rupture of membranes, bleeding, PV, burning, micturition, sir. No history of maternal fever or any foul smelling liquor. No history of oligo or polyhydramnios. USG scan showed the same, water in the head in the mother's words. Mother was referred to a tertiary care center in labor for delivery. She was taken up for LSAs in view of large head detected antenatals.
All right. For example, now every head has a water in it, right? After all, that is CSF. So this scan report does not really 100% say that there must be something wrong. But we take a note of that. I would have been happy if this is a second para. Okay.
Yes.
Was the first baby born normally, vaginally?
Yes, sir.
Yeah.
Yes, sir.
So if the first delivery was normal,
Yes,
they
sir.
could have given a chance for this delivery unless they could know that yes, the head was large and could not be delivered. Okay.
Yes.
So
Yes.
I may not go directly with this scan report to say that I must plan a cesarean section. I would be very comfortable to give a trial, and then I know that, oh, that's not going to happen. I would do a cesarean. Just to make a note that interpretation of antenatal anomaly scan at times can be very, very risky unless the abnormality is outright easy to make out. So keep
Okay,
that
sir.
in mind.
Okay.
Typically,
Yes.
antenatal scan shows hydroureter. Okay,
Yes.
it's
Yes, sir.
not rare at all, and really
Yes.
there is no hydroureter
Yes, sir.
because during the ureteric peristaltic movement, some segment of the ureter looks a little large, and they feel that it's a hydroureter. Okay,
Okay, sir.
so
Okay.
we would take a note of that. Good, go ahead.
Okay. Yes. Natal history. So it's a term gestation. So baby cried immediately after birth. At birth, a head circumference documented as 27.5.
Now can you imagine now? We were discussing a large head,
Yes, sir.
and
Yes,
now
sir.
we have a small head.
Small
These are
head,
the
sir.
point. Okay, but
Yes.
I
Yes.
want to ask you one question at this point of time. Can a
Yes, sir.
small head have a extra water in the brain?
So any a perceived brain malformation leading to dilatation of the ventricles. As a large head, sir, intrauterine infections, intrauterine infections.
See, largely excess of CSF in the ventricular system will
Yes, sir.
produce a large head.
Yes. Yes.
So my
Yes.
question is, can a
Yes.
small head also have a
Yes, sir.
ventricular dilatation?
So this intrauterine infection like toxoplasmosis.
Toxoplasma really gives you a real, genuine hydrocephalus
Yes, sir.
with a large head,
Okay,
not a
sir.
small head.
Yes,
So the point is, if there is a severe cortical atrophy,
yes, sir. Yes.
then to fill the gap,
Yes,
the
sir. Yes.
ventricles look a little large, and
Okay, sir.
it's not a real hydrocephalus due to any obstructive malformation,
Yes,
but
sir.
it's a compensator to the atrophic
True.
cerebral cortex.
Yes, sir. Yes, sir.
So
Yes.
keep a note on that, and
Yes.
a good USG scan might show a little extra water, but that
Yes, sir.
may mean a passive dilatation of the ventricular system in a
Yes, sir.
cortical atrophy. Okay,
Yes,
so
sir.
we'll take it further on that. Okay,
Yes.
go ahead. Go ahead.
Yes, sir. Baby was sucking well at the breast, sir, on day 1 of life, sir. Birth weight of 2.45 kg, sir. Passed urine and stools on day 1 of life. The baby was breastfed on day 1 itself, and no history of respiratory distress, neonatal convulsions, or any neonatal hyperbilirubinemia.
All right, go ahead.
Postnatal history, sir. USG abdomen and pelvis was done, which was normal on day 3. Cranial USG could not be done due to closed AF, as mentioned by radiologists. MRI brain fundus, BERA, 2D echo, genetic counseling was advised, but not done by the parents, and wanted to get it done on the later dates. The reason being there was increased COVID cases during that period, hence discharged against medical advice. Baby was taken home and exclusively breastfed for 4 months, and but Ragisari was started at 4 months. Mother was advised to take the child to tertiary care center for when gone for immunization and evaluation by Anganwadi workers. In view of lockdown, could not be taken, and hence no immunization and evaluation was done, sir.
All right. Now, at this point of time,
Yes, sir.
you have an immediate postnatal history which looks normal.
Yes, sir. Yes,
the baby cried immediately, baby started sucking at the breast, etc. Would
yes,
you
sir.
anticipate a delayed development in this child at this point of time?
Yes, sir. So only one thing, sir, which highlighting is the microcephaly, sir.
Okay.
Good. That is one thing, sir, which I would reflect on the developmental delays.
Okay,
apart from
good.
Yes,
Good. But tell me, which microcephaly
yes,
can
sir.
be an intelligent child? Forget the delayed development. Normal. So is is every microcephaly a delayed development?
No, sir. Familial microcephaly, there could be a normal.
Excellent, excellent. So your answer should have been at this point. You are right.
Yes, sir.
You came up correctly. That
Yes,
you
sir.
would have said, I like to examine the mother and father for the head circumference.
Okay, sir. Okay.
Because it's an
Yes, sir.
autosomal dominant microcephaly,
Yes, sir.
which has a normal mentation. And
Okay.
I think that point you made it very, very well. So
Yes.
at this point of time, I
Yes,
won't blame that. But
Yes. Yes,
having
sir.
said that,
Yes,
can you
sir.
still consider in this child
Yes, sir.
that microcephaly must not have been just the autosomal dominant familial one, but
Yes,
must be
sir.
pathological one? Can you guess that?
Pathologic one, sir, because
See,
the
we are at the birth of this child. We
Yes,
have not had a story of delayed development.
Yes, sir. Yes, sir.
We only know that this child has a microcephaly.
Yes,
And we don't have both mother and father for looking at their head circumference. So
Yes. Yes,
can you guess that this is definitely pathological? And the answer is
Yes.
both the scans at second trimester and the third trimester had shown excess of fluid, which means that this must be an abnormal cortex with a passively dilated ventricular system.
Okay,
Whereas in a normal autosomal dominant microcephaly with normal brain, there was no reason for somebody demonstrating on USG an extra fluid. So if that extra fluid is the right interpretation, then I know this microcephaly is pathological and I expect a delayed development. But one more point, at this point of time, do you expect a very severely delayed child or a very minimally delayed child?
So I think very developmentally, sir.
All right. And therefore,
Sir,
your answer, yes. So if in the second trimester the head was having some extra fluid, and we have come to conclusion that that must be a passively dilated ventricular system, then this child will be severely delayed. Okay.
Yes, sir.
So
Yes, sir.
imagine if you were a neonatologist attending the delivery of this child, right at birth, you could have started feeling that you are going to get into trouble on this child. Though you may not have to spell it to the mother right at that time, that is not right. But you would have insisted on them to come back to you at another 4 weeks' time because you are worried that this child is going to be somewhere abnormal, right? Good. Go ahead. Go ahead.
Yes. So HOPI is a neurodevelopmental history. Mother noticed to have delay. Mother noticed to have a delayed attainment of milestone at 6 months of age as compared to the first child in the form of not attaining head controls. Mother noticed that there's persistent twisting of both the hands, unable to bear weight on the hands, lift the head off the couch, and no reaching for objects. Also noticed to have difficulty in putting on diapers and stiffening of all 4 limbs, lower limb more than the upper limbs. There was no history of seizures or any tonic posturings. Mother tells the baby never fixed its eyes to her and no social smile attained. Child used to cry excessively even after feeding wells. Child used to respond for loud noise in the form of opening hands, but no response to the lights. Baby used to suck well at the breast since birth and also swallowed well with no nasal regurgitation and pooling of secretions and no success cycle due to discoloration of skin. No history of prolonged feeding, no history of drooping of eyelids or deviation of the eye or the face, no history of tongue thrusting, choking episodes, repeated respiratory tract infection or previous hospital admissions. Baby cries to pain sensation and change in temperature. No history of involuntary movements, no drooling of saliva. No history of immobility of the joints, bed sores, or arching of the back. History of one positive is history of poor weight gain is present. No history of fever, vomiting, loose stools, oily stools, or abdominal distension. Physiotherapy was taught by Anganwadi worker at 5 months of age. Hence, putting on diaper has become much more easier.
All right. Now, just go back on one slide. Go back on one slide.
Yes.
And you made a point about crying. Okay.
Yes.
Now, what does that mean to you?
Yes, incessant crying, sir. That is one of the early, the child, the excessive crying is one of the early markers of abnormal brain development. That is CP, sir. One of the early marker of development. Yes,
Very good. But tell
yes.
me,
Yes.
Why is that early marker? Why should such babies cry?
So one is due to pain, sir, due to increase in spasticity. Developing spasticity can lead to pain.
Well, spasticity is not necessarily pain.
Yes, sir.
Okay.
Yes, sir.
After all, it's a change in the muscle tone, which
Yes, sir.
means a passive resistance to the movement. But
Okay.
it's not necessarily painful.
Yes,
so why is this baby crying excessively? And the reason is,
yes,
for the baby to be happy,
yes,
there
sir.
must be a cognition to some extent, vision to some extent, and hearing to some extent. When the baby cries and mother talks to the baby
Yes,
perceives the sound and stops crying. Okay.
Okay.
So
Yes, sir.
same thing about the vision. Okay. And same
Yes.
thing about other inputs of sensory system. For example, when the baby is crying and the mother
Yes.
holds the baby close to the baby's close to her abdomen, the
Yes, sir.
baby starts keeping quiet. So the point is, babies who don't have adequate sensory input to respond to whatever is happening in the environment just are confused and keep on crying. You are right that excessive crying could be the first marker
Yes,
that
sir.
there is something wrong in this baby's perception of sensation. And what it is, we won't know at that point. It could be that the cortex is not able to perceive. So there is a cognition defect. And therefore, this baby feels that the baby is left alone in this world with nobody to interact, and the babies are upset. So take a note, and I was very happy when you said that excessive crying could be a marker of a delayed development. But having said that so correctly, tell me, what are the other causes of excessive crying in almost a newborn?
So one seizures.
Okay.
Seizures and any GERD can.
Very good. So the commonest cause of crying really at all ages is trauma.
Trauma.
Okay.
Yes.
And if there is some trauma during delivery or whatever, okay,
yes,
that's the commonest cause. Neurological, of course. There could be a mild respiratory distress.
Yes.
And the babies cry in the hope of getting better oxygenation. Okay.
Yes.
So all these comes to mind, but you are right. Incessant crying for a long time would mean that there could be a marker of that. Very good. Go ahead.
Yes.
Development.
Yes, developmental quotients. So global developmental delays, but gross motor development at present only partial neck holding. So developmental quotient of 24%. So fine motor only grasp is present. So developmental quotient of 15%. Socially cries excessively, decay of 10, and language no cooings. Again, developmental quotient of total average of 18%. Family history is a non-consanguineous marriage, first child alive and healthy, 4-year-old girl child. No history of developmental delay, developmental regression or ptosis in the family. No history of any mental retardation in the families.
Good.
Immunization. Yes. So I'll continue, sir.
Yeah. Please continue.
Yes. Immunization histories. Only BCG, opioid 0 dose, and hepatitis B birth dose was given. So no further vaccination was given at PHC. Sir. It was advised to take it at higher center due to small head. Is that what in the mother's words?
Fine. At this age, knowing that this child has a severe delayed development,
yes, sir.
Would you have allowed this child to take a DPT vaccine?
No, sir. If you are considering a progressive disorder, sir, then it is better to avoid wholesale pesticide vaccine.
So, do you mean that you would take a risk of this child getting these 3 infections in life? How would you look at that?
So if we have diagnosis as static encephalopathy, sir, then it wouldn't be a. But since there is no diagnosis, sir, if it is a neuroprogressive disorder, then we would have avoided.
Very good. And therefore, your answer is D and T are safe anyway.
Yes, sir.
It's the P that is bothering us, and
sir.
more so if it is a progressive disorder.
Yes, sir.
So by the time we know that this is static, we would not mind given even DPT. But the point is that it's not that a cellular vaccine will not react. So D and T are all right, and P is also all right if there is a static damage, but we have to be sure that this is not progressive. Good. Go ahead.
The nutrition is on transition diet, sir, and on semi-solid foods taking orally. Socioeconomic history, class 4 as well modified Cooper's scale. Summaries.
Yeah, go ahead.
1 year, 2 months old female child, so born to a non-consanguineous married couple with no significant family history but significant antenatal history with incomplete immunization on transition diet, belonging to upper lower socioeconomic class with global developmental delay with spastic quadriplegia UMN type of all 4 limbs with microcephaly with vision abnormality, hence involving the gray matter and white matter of the brain, cortical involvement, and with no seizure disorder, probably secondary to any intracranial malformation.
Okay. I think so far you are opining only on the history.
Yes, sir.
So you do not know necessarily few things that you have mentioned. You're right. Okay. You are not sure whether it's a quadriparesis. You may be reasonably right that you have a spasticity because there is a story suggesting spasticity. But tell me that you have guessed only on the history that there is a spastic quadriparesis.
So as per mother, sir, she tells that all the 4 limbs are involved and baby persistent fisting, sir, and keeping the hands in the flex position at the elbow, sir, as well as legs, difficulty in putting on diapers and clothes. Sir. That points out towards the spastic diplegia, sir, both the legs and the upper limbs in the flexed position always again points out to the upper limb spasticity, sir. So since all the 4 limbs are involved, so
could it be a all right. Could it be a diplegic CP? Where all the limbs are involved, but the lower limbs are more involved than the upper limbs. So your answer is the diplegic CPs are not so severely delayed.
Okay, sir.
Whereas this child seems to be severely globally delayed, and therefore it must be a spastic quadriplegia. Or could it be a dystonic CP?
Since there is no posturing and involuntary movements associated, so then can we rule out?
No. So point is, dystonia sometimes may not be obvious to the history taking. Okay, sir. Because after all, what is dystonia? How will you define dystonia?
Sir, it is posturing on the any movement, persistent posturing with the movement of the limbs, going in for posturing.
Yeah, somebody on the chat is saying abnormal tone, but it is abnormal tone. So your answer is dystonia is a twisting movement.
Yes.
You know, they do this twisting. It's also increased tone, but twisting. And sometimes the twisting may not be obvious to the mother, but for an examiner, he will have to induce the child to show twisting. Okay. This brings me to one more point. Could a child of spasticity, which is upper motor neuron, also have a dystonia, which is basal ganglia? Can these two tones be present together in one same limb?
Yes, sir. Yes, sir. It can be present, sir.
Why?
Sir, initially there could be a hypotonic stage which with the dystonia, which later on progressing to spasticity and dystonia.
Very good. So what you meant was that at times not only spasticity and dystonia may be together, but even a hypotonia may be together.
Okay, sir.
Because you are seeing a transition stage. Okay.
Yes, sir.
Now,
Yes, sir.
at this point, tell me, why should a central lesion have
Yes,
a
sir.
hypotonia? I thought central is always increased tone,
Yes,
and
sir.
the peripheral is lower motor neuron. That is hypotonia.
Yes, sir.
But why? What is central hypotonia?
Central hypotonia, sir. The central hypotonia is the cause could be, sir, HI, hypoxic ischemic encephalopathy, or any intraventricular hemorrhages leading to central hypotonia.
But all that
yes.
is upper motor neuron, no? Why
Yes,
hypotonia? So the reason is,
yes, sir.
all tracks which go from higher cortex to lower center, like for example, the tracks going from cortex to the cerebellum will have a hypotonia, because the cerebellar involvement is there. So in other words, hypotonia in a central lesion means quite an extensive lesion all over the cortex, not only to the pyramidal tract, but to the entire cortex. And now today we have given up the title as hypotonic CT. There is nothing like hypotonic CT, but there could be hypotonia in a cerebral palsy out of a central lesion, which means that all connection from the cortex to the lower center are also disturbed. And to that extent, the lesion is extensive, and because the lesion is extensive, such a child is extremely severely delayed in development. Whereas if it is only spastic, he may not be that severely delayed. Okay. So point is, in an examination, you will pick up all three types of tone. The hypotonia, spasticity, and rigidity, or dystonia, and explain the examiner that these are the different fibers which are also involved, right? Good. So now you have said that there must be an intracranial malformation.
Yes, sir.
What do you think? There must be a localized malformation?
So, since there is a diffuse cortical involvement, sir, involving all the development like social as well as language, sir, and just not the motor, sir. So there could be a diffuse involvement, sir.
Excellent. And therefore, there is some malformation almost scattered all over the higher center, and you are expecting tachygyria or whatever. Okay. We will not be able to guess only on examination, but you are right that this is a diffuse malformation, and that is causing all this. Very good. Let's get to the examination now.
Okay. General physical examination. Child is alert and conscious, lying on the mother's lap, not fixing its eyes at the mother and not interested in the surroundings. Vitally stable. Head, small head, as a head, which is a small head, receding forehead, so temporal hollowing, and metopic suture prominence is there, and AF is closed. Eyes, widely spaced eyes from each other, no corneal clouding, cataract, or any signs of vitamin A deficiency. Ears are large ears as compared to the head. Face, a triangular face. Nose, depressed nasal bridge. Hands, fisting with cortical thumb is present bilaterally. Chest, no signs of rickets. Skin, hyperpigmentation of the knuckles. No neurocutaneous markers or no contractures.
Now, at this point of time, how did you know that this baby is conscious? He's not interested in surroundings. Okay.
Yes, sir. Yes.
So, how do you know he's conscious?
Sir, it is crying and it is alert. It's opening its eyes and feeding also, sir.
All right. And therefore, I want you to use simply AVPU. You know AVPU?
No, sir.
A for alertness.
Yes, sir.
V for responding to voice.
Okay, sir.
P for responsive to pain.
Okay, sir.
And U is unresponsive.
Okay, sir.
So AVPU. Okay? So you could say that this child obviously may not respond to your voice because there may not be hearing.
Yes, sir.
Okay.
Yes, sir.
But you can almost elicit painful response. And to that, further you say that if this
Yes.
child is crying without any response,
Yes, sir.
surely this child is conscious.
Okay, sir.
Okay. So
Okay.
that's how you say that this child is conscious but not alert.
Okay, sir.
So
Okay.
simply in pediatric neurology,
Okay,
even
sir.
higher functions are not easy to pick up, unlike in adult. Because
Yes, sir.
in an older child or an adult, you can ask for memory or recent events, past events, all that. But in a small child, AVPU is a good idea to tell me how is the higher function of the child. So
Okay, sir.
take a note of that.
Sure, sir.
Otherwise,
Sure, sir.
you have correctly given all the findings so far. Go ahead.
Yes, sir. Thank you. Anthropometry, sir, weight for age, sir, it comes to -2 to -6, which is moderate underweight, sir. The present weight of the child is 6 kg, sir. Length for age is less than 3 standard deviation, which just shows stunting, sir. The present length is 63 centimeters. Head circumference is less than -3 standard deviation, microcephaly, sir, 32 centimeters. And weight for length comes to -1 to -2 standard deviation. Mid upper arm circumference is 12.5 centimeters.
So do you think this child is malnourished?
So it's just moderately underweight, sir, with stunting, chronic malnutrition.
Okay. What's your comment of weight for length is between -1 and -2? That may not be abnormal.
Yes, sir. Since there is both weight and length is affected, sir.
So then, do you think it's still malnourished child with weight for length, not very abnormal? Between -1 and -2, you can consider it as lower limit of normal.
Okay, sir.
If it goes beyond -2, you are
Okay.
definitely abnormal. Between -1 and -2, you may have a borderline normality or borderline abnormality. Okay.
Okay.
So,
Okay.
point is, weight for length is a good idea to go by. But there would be another way to assess whether this child is quite severely malnourished. For example, are you aware of the birth weight of this child?
Birth weight of child is 2.45 kg, sir.
All right. Now, today's is 8 kilos. So how many kilos has he gained in the last so many months?
1 year, 2 months, it's gained. Today's weight is 6 kg, sir. So he has gained around 4.5 kg.
Fine. So one is
3.5. 3.5.
Okay.
Yes.
So let's say 4 kilos he has gained.
Yes, sir.
Okay. Now,
Yes, sir.
when does the child gain 4 kilos in the first year?
So at
Normal child.
around 4 kg at 3 months, sir.
All right.
2 to 3 months.
So
yes.
you can go a little higher, even 5-6 months.
Okay.
By 3 months, you have picked up 2.5 or 3 kilos.
Okay.
And by 5-6 months, you could have picked up 4 kilos. Okay. So
Okay.
let's say that the weight age
Yes.
of this child is about 5 months or whatever. Okay. Now,
Yes, sir.
you may not be knowing the length at birth,
Yes.
but presume it's 50 centimeters.
Yes.
What is the present length of this child?
63 centimeters.
Okay. So at what age is this height is normal?
Sir, at 6 months, sir.
So
6
around
months.
same. So now look at weight age is around 6 months. Length age is around 6 months,
Yes.
which also means that weight for length is nearly normal.
Okay.
And if weight for length is normal,
Yes,
then
sir.
you consider this not as malnutrition, but
Yes,
there
sir.
could be a familial thinness or a small stature, or it could be just the individual one. So we will not call this child malnourished. But suppose in an exam you say that this child is malnourished.
Yes,
Then
sir.
I would ask you, you said this child is feeding well.
Yes, sir.
And,
Yes, sir.
and was given breastfeeding in the first 4 months, then ragi, etc. Why is this
Yes.
child malnourished then? So my question putting the other way around. Yeah,
yes.
Go ahead.
So, since there is spasticity and baby is requiring higher efforts to overcome its movements, and a higher basal metabolic rate.
See, spasticity merely does not increase the basal metabolic rate. It's the muscle spasm that might do it. There are two different things. Spasticity and muscle spasm are two different things. So this child may not have an excess of outlay of calories because of basal metabolic rate. So point again, I want you to make out is if this child is feeding reasonably well and this child does not have any choking or aspiration events, then this child should have grown well. And now we know that this child has not really been very malnourished, but has been of a small stature. And that's why we are not worried about any specific reason for this child being undernourished. You can call him underweight, but that is not malnutrition, and that is the familial or it's just an individual pattern, right? So I think what we have learned is when you consider anthropometry, weight for length is the most important part, and you can also try to find out the weight age and the length age, and if both are nearly similar, then you know that this child is not malnourished, but this child is of small stature. All right? Very good. Go ahead. Go ahead.
Thank you, sir. Then comes the 180-degree flip test, sir, which shows supine and the extended lower limbs with flexed upper limb. I have the pictures and portions. Then pull to sit, there's partial headline. Sittings are partially curved with prominent spines, which is suggestive of any paraspinal muscle weakness. And the neck is bent. Vertical suspension, extended legs. Ventral suspension, head and the body in the same plane, legs hanging down. Prone position, hip joint flex and does not lift the head off the couch. So this is the...
All right. Now tell me that if this child is spastic, why pull to head is lagging behind? You get the question? Hello? 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 Can you hear me?
Yes. Hello, sir.
Can you hear me?
Yes, sir. Yes, sir. I can hear you, sir. I'll come back. I'll just I'll put it down.
Yeah.
See my screen. So it's on.
Good.
Yes.
Now, I was asking you that in a spastic condition, many times the parents come and say that the child started holding head even at 2 months of age because
Yes,
of
sir.
spasticity.
Yes, sir.
But here you are showing me head
Yes,
lag even
yes,
at a year and 2 months. Why is
yes.
that?
Mm,
And this is exactly what I told you, that in a
yes,
given
sir.
child, you
Yes,
can
sir.
have hypotonia at some place,
Yes, sir.
spasticity, upper motor neuron, sometimes extrapyramidal, sometimes dystonia.
Yes.
All can be together depending
Okay.
on which fibers are involved to what extent.
Okay, sir.
And therefore, the neck muscles are really hypotonic. That's why there is a head lag.
Yes, sir.
Now,
Yes.
another cause of head lag could be a very large head, but this child doesn't have a large head. In fact,
Yes,
this
sir.
child has a small head.
Yes, sir. Yes.
So, this means that there is some probable axial hypotonia. Okay. And
Yes, sir.
this is one example of how hypotonia and increased tone can go together in a given child. Right? Good.
Yes.
Go
Yes.
ahead. Go ahead.
Thank you. Systemic examinations, so CNS, higher mental
Yeah.
health. I'm supposed to use AUP, AVPU, sir. I'll just change it, sir. Then I'll make a note of it. So there is startle response to the loud noise. It does not follow the light, but blinks to the lights. Cranial nerve, sir. Olfactory could not be assessed. Optic nerve, blink reflex is present, sir, and fundus is normal. 3, 4, and 6 now, there's no ptosis, but there is left esotropia. No nystagmus, pupils bilaterally equal and reactive. Fifth now, sensations are present, sir, and jaw jerk not exaggerated. Seventh nerve is normal. There's no deviation of the face. Eighth nerve, startled response is present. Ninth and 10th, the gag reflex is present and uvula is central. 11th now, movements of the neck are present. So 11th now, there's no deviation of the tongues.
Now tell me that you said that the child is not even blinking to the light, right?
Yes, yes,
That means vision is involved.
yes.
But you said fundus is normal and the second nerve is normal.
Yes, so there could be cortical blindness.
Very good. So it also tells you that the lesion is extensive.
Yes,
Okay.
sir.
It is on the motor cortex, frontal cortex, okay,
Yes.
auditory, occipital, everywhere. The
Yes.
lesion is quite extensive. Good.
Yeah.
Go ahead.
Yeah. So motor systems, the bulk is bilateral symmetrical, no wasting. Tone is increased tone bilaterally, upper limb more than the lower limbs. Power 3/5 in all the 4 limbs, best visible power. Reflexes, primitive reflexes. Then near this something neonatal reflexes and primitive. This in neonatal reflexes come under primitive reflex itself. Per se, neonatal reflexes are cross extensor reflexes, which is positive. Suprapubic reflex, heel reflex, and dorsal lemurs reflex are negatives. Grasp reflex is present, placing reflex is present, Moros is absent, ATNR is absent, so Gallant's is absent, and even parachute is absent.
So what do you make out of this primitive reflexes?
Yes, primitive reflexes, the frontal lobe hasn't been developed appropriately, and there is there's no inhibition of this primitive. There's persistence of primitive reflexes. So one of the causes CNS cortical involvement.
All right. Would primitive reflexes give you also
Yes,
the
sir.
developmental status of the child, the degree of developmental delay?
Yes, sir. Yes, sir.
So now tell me, grasp reflex and is present, right?
Yes, sir. Yes,
so
sir.
what, palmar grasp or plantar grasp?
As a palmar grasp.
Okay.
Grasp.
So
Yes.
what does that mean? What is the developmental age when the palmar grasp is still present?
Sir, 1 to 2 months.
Fine. But the Moros is absent.
Moros is absent.
So then why that?
Probably due to spasticity, sir. Is it?
Very good. And therefore, again, the point I want you to take a note is that
Yes,
not
sir.
all primitive reflexes will appear or disappear at a given standard fixed time.
Okay, sir.
There could be a little early or little late, and
Yes,
therefore there could be a possibility that grasp reflex palmar is still present. And if it is present, you might also say how strong is the grasp reflex, because
Okay.
the grasp reflex at 1 month, 2 months, and 3 months is gradually disappearing, and
Yes, sir.
therefore it's becoming less and less strong, getting more and more weak. You know
Okay,
that
sir.
at a newborn level in the first month, you can
Yes,
just
sir.
pick up the whole child with only your thumb. The child holds it tight, grasp reflex.
Yes, sir.
So, but the morose is absent.
Yes, sir.
So, do you think that morose is absent because upper limbs are paralyzed?
Yes, sir. Spasticity.
No, spasticity is tone is increased. But do
Yes,
you
sir.
think the power is not there, therefore it doesn't move?
Uh, so don't.
So you would have said that the upper limbs can be moved
Yes.
by giving a painful stimulus, but the morose is absent. So
Okay.
morose absent means morose has disappeared maybe, or
Yes.
it cannot be elicited. And you are rightly saying that if he is very spastic, then he has movements which are not as well. Which also
Okay.
puts you to say that when there
Yes.
is an increased tone of
Yes, sir.
this kind, you can even grade the tone.
Okay, sir.
Okay.
Okay,
And
sir.
if there is a severe spasticity,
Yes, sir.
then the movements at each joint are tremendously restricted.
Okay, sir.
Whereas if you have a early spastic tone or just an early upper motor neuron spasticity, you can
Yes, sir.
easily move all the joints involved. But
Okay, sir.
when the spasticity is very severe,
Yes.
you cannot even move the joint. And that is
Okay.
one reason why morose is absent in this child. You are right to say that it is because of spasticity, but also add a word
Yes, sir.
because of severe spasticity
Yes, sir.
interfering with movements of the joint. In other words, range of movements of joints is tremendously affected in a severely spastic child.
Okay,
Good.
sir.
So you have done very well in analysis of how grasp is very much present, but the
Yes, sir.
moro is absent. Right?
Yes.
Okay, go ahead. Go ahead.
Yes. Thank you, sir. So these are the superficial reflexes and deep reflexes. All the deep reflexes are exaggerated, sir. And bilateral plantar is extensor, sir. With ankle, then no, and ankle and knee, there's no clonus present, sir.
All right. Would you do a patellar clonus also?
So the development of patella.
Yeah,
Yes.
but that's right. Good. And what
Uh,
about jaw jerk?
so jaw jerk is not exaggerated, sir.
So, do you think jaw jerk is normally present or not present?
So, uh, so,
So, jaw
so it is
jerk
not.
is jaw jerk is almost absent normally
Yes, sir.
or very minimally demonstrable.
Okay, sir.
But when it is demonstrable,
Yes, sir.
it certainly means abnormal.
Yes,
And
sir.
what does it mean? What abnormality?
So it's a pseudobulbar palsy.
Excellent, excellent. Good,
Yes.
very
Yes.
good.
Thank
Go
you,
ahead.
sir. A cerebellum, sir, no positive signs of cerebellar dysfunction, sir.
All right.
Sensory appears to be normal, sir. Cries to pain and spine is normal, sir. No signs of meningeal irritation and angle, sir. Uh, there is a severe degree of hypertonia, sir.
Very good. All other systems are normal.
Yes, sir. Other systems are normal, sir. Developmental
Okay.
assist.
All right.
Others, no hepatosplenomegaly, sir, and no murmurs, and respiratory is also normal, sir.
All right. So now, what is your summary ultimately of physical examination and also the history?
Yes, sir. So it's a 1 year, 2 months old child with significant antenatal history, sir. With history of with positive history of with positive antenatal history and no family history. At the history level, we pointed it out to a CNS cause, CNS lesion, and after examination, sir, our examination finds were consistent with the history as per the mothers. So we would, and since all the domains are all the domains have been delayed, so we take it as a global developmental delay, sir. with the increased tone in all the limb, indicating to spastic quadriparesis. And on an anthropometric examination, there has been documented microcephaly, and there's no history of any seizures or contraction even in examinations. And examination confirming the history of vision abnormalities. And since there is a response to loud noise, we have to rule out any hearing impairments with moderate underweight and stunting with incomplete immunization status.
Very good. 2-3 points on examination. Do you think there are any contractures in any joints?
No, sir. As per exam, there was no contractures.
All right.
Yes.
How do you differentiate dynamic from static contracture?
Yes. Dynamics. Like after there's a there's a R1 and R2, sir. Range of movement.
Excellent. So excellent. Moment you say R1 and R2, I know you know it very well. Good. You should just start saying R1, our examiner knows you know everything well. One more question on this is, you said that this child has got a microcephaly and your anterior fontanelle was closed because ultrasonography could not be done of the cranium because the anterior fontanelle was closed. So I thought this is a craniosynostosis because fontanelle is closed.
Yes, sir.
So sutures must have been already fused, and this is a craniosynostosis and not primary microcephaly.
So there was one metopic which was prominent, sir. Metopic suture prominence was there, sir.
All right. Not so easy to make out, right? You are right. But tell me something better, that this is not just a primary craniosynostosis, but it's a primary microcephaly, as we call it. Because craniosynostosis patient is never delayed development. In fact, a craniosynostosis, if it is involving all sutures, may come with increased intracranial tension.
Okay, sir.
And that could be one cause of excessive crying in an infant.
Okay, sir.
Now, so when you saw a microcephaly and excessive crying,
yes, sir,
you had to rule out a craniosynostosis also, because at that point of 4 weeks, you had no idea whether this is going to be developmental delay.
Okay,
so
sir.
now tell me, what is the clinical finding which positively tells you that this is craniosynostosis? I want you to examine a child and tell me that this is craniosynostosis.
Sir, like on putting the hand over the head, sir, there'll be either stepping or ridging, sir.
Yeah.
Stepping.
One thing you said that the sutures are prominent, but that's not easy to make out. But what your answer should be that if you keep 2 thumbs on the side of a suture,
sir,
and try to press 1 thumb,
sir,
normal skull, if the
sir,
sutures are not fused, can move about a millimeter or so.
Okay, sir.
Which means that the sutures are not fused.
Okay, sir.
And therefore, on clinical examination at birth, in a microcephaly, you make sure that this is not craniosynostosis. By, of course, you said rightly that sutures are not prominent, but also you try to show that the bone can be moved about a millimeter by pressure, telling you that sutures are not fused. Okay? Good.
Okay, sir.
But in a child of craniosynostosis, child is never delayed in development. In fact, it comes with an increased ICT. Okay? Good.
Okay, sir.
So now before you give me your investigation,
sir,
tell me, why do you need to investigate this child? Your diagnosis, you have already told me that you are considering malformation in this child.
Yes.
Okay.
Sir.
You are not considering any other brain damage due to hypoxic ischemic injury. Okay.
No.
You are not looking at a progressive neurological disorder like a neurodegenerative disorder.
Yes, sir.
So,
no, sir.
What's the advantage of doing a further test on this side?
Since there was a antinatal detected abnormality, sir, we have to confirm it by doing a MRI like postnatally.
All right. Suppose the parents say that, what is the outcome of your MRI finding to help the child? What would be your answer?
So to rule out any per se cerebral atrophy is there, sir. That cerebral atrophy so to go in for any genetic genome sequencing by looking at the MRIs, any genetic this thing, and advise a genetic counseling for the parents.
Good. So the point I'm making is, in such a child, you will have to kind of counsel the parents well even before ordering the test. And you will have to tell them that to find out what are the abnormalities in the brain malformations, we must do a neuroimaging, MRI, and it may not directly help in terms of management, but indirectly might help to see whether subsequent delivery, whether we can avoid occurring the same problems in the next period. So that must be made clear. All right. So let's see, what investigations have you done?
Yes. So investigation, MRI brain, sir, and it fundus was done. So only those two investigation as done presently, sir. The other plan was to do IM workup, sir, and a 2D echo, sir. So there was just an investigation. The primary is the MRI, sir. Then to roll out vision, this thing fundus we had done. Only those two could be done, sir. Others are yet to be done, sir.
Why not CT scan? Why do you want MRI?
To rule out brain parenchyma abnormalities, sir, MRI brain would be useful. So to rule out craniosynostosis, again CT scan will be.
So do you think CT will not show that?
It will show, sir. It will show.
See, the problem with MRI is you will have to give anesthesia.
Yes, sir. Yes.
And or at least sedation.
Yes.
And CT could be done without sedation.
Yes, sir.
Now, why do you think CT does not need sedation, but MRI needs sedation?
So it's a short, it's just 15 seconds. Well, MRI will require 20 minutes.
But CT also takes some time, no? CT is not just a minute or two. So point is, MRI images are disturbed by motion.
Okay.
And CT scan, no. So you don't want any motion at all.
Yes.
You need to have not even a spinal motions. Therefore, you need a sedation. But what is an advantage of MRI over CT scan?
So the brain abnormality involving the gyri and sulci can be detailed. Brain parenchyma studies could be.
All right. So your correct answer would be, MRI can differentiate gray from white matter.
Okay.
Whereas CT cannot do that.
Yes.
But in this child, you are not looking separately a gray matter or a white matter disease. You are looking at a malformation, which could be picked up even by a CT. So that is one. MRI is done when you want to see the sub part of the same part of the brain. Like if you have a cortex, I want to see gray matter and white matter separately. Then I have to have an MRI because the CT will not show that.
Yes, sir.
The other indication of a MRI over CT scan is, CT scan is a rather poor for a posterior fossa.
Yes.
So posterior fossa is not very well delineated by a CT scan, which is well delineated by MRI. And therefore, if you are looking at a posterior fossa pathology, you might prefer an MRI. Therefore, MRI generally for neurodegenerative disorder, and a CT for obviously for a disease like TB, meningitis, etc., where you want to see not a very small part of subpart of cortex, but you want to have a general idea about it. So here you are right to say that, yeah. But at the end of this 1 year, 2 months,
Yes,
are you still worried whether this could be a progressive disorder?
No, sir. A neuro progressive, no, unlikely, sir. There's a microcephaly with spastic so highly, it's a static.
But now tell me that this child is so delayed developmentally,
yes,
that even if this child has got a progressive disorder, there is nothing left for him to show further delay.
Okay, sir. Yes,
then
sir.
how will you rule out a neurodegenerative or a progressive disorder? You get my point.
Yes, sir. Neuroprogressive. It's no hepatosplenomegaly or.
So now tell me, when the child is severely globally delayed,
yes, sir.
How do you differentiate static from progressive disorder? When the baby is moderately or mildly delayed, it's easy.
Yes, sir.
Because your
yes,
DQ has remained constant over a long period.
Okay, sir.
That is static. And if DQ is going down gradually, then that is progressive.
Okay, sir.
But when DQ is so low,
yes, sir.
there is very little to go down further.
Yes,
then
sir.
how will you pick up a progressive disorder? And that is one reason why you would argue in favor of an MRI. Because you are right that this is not progressive. But if you are pushed on to say, tell me clinically whether it is progressive or not progressive, your answer is simple. The neurodegenerative disorders, babies are born normally.
Okay, sir. Okay, sir.
Babies are not abnormal to begin with.
Okay, sir.
Whereas this baby has been abnormal even antenatally.
Yes, sir.
And you have a head circumference which was so low that it was obviously a origin of this problem has been way back antenatally, whereas a neurodegenerative disorder is normal at birth. Therefore, I have ruled out a probable neurodegenerative disorder. Right?
Okay. Yes, sir.
So good.
Thank you.
But now tell me, why is neurodegenerative disorder normal at birth?
So neurodegenerative because the brain development has been normal, so in neurodegenerative disorder. It will start only after it is exposed to any storage disorders, and if the brain start, there'll be no progressive myelination, sir.
Good. So what you mean is neurodegenerative disorders, most of them are errors of metabolism.
Yes.
And errors of metabolism start manifesting earliest only after feeding.
Yes, sir. Yes,
and not till then.
Yes.
Therefore, the earliest metabolic disorders will present after the baby has been ingesting breast milk for about day 2, day 3, and then suddenly manifest with vomiting, seizure, etc.
Yes, sir.
So that is the reason why this child cannot have any progressive disorder, and to that extent, you might not need MRI. You might get away with CT also, but you are not wrong in saying so. But we already discussed that for neuroimaging for parents, it is going to mean a lot of difference in the management of a child. Whereas you and me know that at best the difference could be in labeling the correct etiology or pathology, but not the management.
Yes.
And to small extent, imaging might help to prognosticate the next pregnancy, but that too not necessarily. Okay. Now, would you do a chromosomal study in this child?
Chromosomal to rule out syndromic cause.
Yes.
To rule out a syndromic cause for brain primary microcephaly.
Fine. So you would have said that clinical examination obviously does not show any probability of a chromosomal disorder, but the detailed genetic evaluation is justified to label a problem, but not necessarily manage a problem.
Okay.
All right. Now, besides all these things that you have said,
Yes, sir.
which other investigation you would like to do? I'll give you a clue.
Okay, sir.
You have told me all neurological investigation and also one cardiac. Okay,
Yes,
you
sir.
want to do a 2D echo.
Yes, sir.
Okay.
Yes, sir.
IM workup may not be required. Okay.
Sir. Okay,
but
sir.
Which are the other systems that are often abnormal in such a child, which you may like to evaluate?
The eyes and ears with hearts to rule out the
excellent. Excellent. So
yes,
you have already talked about the bearer and if required VEP. What else?
Yes,
Which other system could give you a problem in management?
So hepatosplenomegaly.
But that you can see clinically.
Yes.
And if that is not there, then you are not worried about looking at any storage disorder. So,
yes,
what are the common comorbidities of such a child?
Comorbidities.
So, the one is GERD.
GERD. Okay, sir.
Okay. And a GERD may not exactly present every time with vomiting or choking, and the child may be suddenly lost with aspiration.
Yes,
one may have to really consider a probability of a GERD, but not necessarily you start investigating GERD because there are no easy investigation for GERD.
Okay,
and you know that all investigation for GERD, call it a barium swallow, call it a milk scan, call it an esophagoscopy, esophageal biopsy, all have a limitation. And then 24 hours pH monitoring is not easy. And further, there could be a non-acid reflux, which is not picked up by the pH monitoring. So you would say that I will go clinically as far as the GERD is concerned. Okay. Now, do you want to also see whether all joints are all right and there is no dislocation of any joint?
Yes. Yes, sir. Yes. Dislocation, any contact, dislocation of joint.
Yeah. So severe spasticity may lead to dislocation of joint, and which joint is difficult to make out on clinical examination unless you try your best to find that out. Hip joint.
Hip joint. Okay.
And therefore, then if this child is excessively crying even now, there could be minor crack fractures because of severe spasticity, and you might miss them.
Okay, sir.
So bones may have to be evaluated, but not as a routine investigation, but after close observation and a good physical examination.
Okay.
All right. Fine. So that. Now come on management. How will you manage this child?
So it's a multidisciplinary approach.
All right. But spell out what is this multidisciplinary approach?
Yes, sir. So it's so any per se for the contractures, physiotherapy and orthopedic involvement, sir. Pediatric neurologist opinion.
All right.
Genetic.
Okay. All right.
Genetic workup and for GERD, for relieving of spasms, relieving of spasms, to try with medical management and surgical management. Medical management to go with the drugs of to relieve spasticity, baclofen, and if there was dystonia, there try hexapinidine.
All right. Would you use Botox in this child?
Yes, sir. That would. Yes, sir.
You will not use Botox because Botox is good for a localized problem. In a generalized problem, how many places you will put Botox into muscles? Okay. So Botox is not a good idea, but Botox is also very transient, temporary. And if this child has a reasonable cognition and his legs are giving you a problem, that is going to come in the way of standing and walking. But otherwise, his brain is not bad. then you could use Botox only for the lower limb muscle. But when everything is globally developmentally delayed, Botox is not an answer to this child. To that extent, you said baclofen, dantrolene, okay, diazepam, whatever, that is all right as far as that is concerned. So that much then about the thing. But don't forget little more details about talking about the other forms. Like you said physiotherapy.
Yes.
What is the idea of physiotherapy in this child?
To prevent contractures, sir.
Very good.
Yes.
Okay.
Yes, sir.
Then would you do an occupational therapy in this child?
So occupational therapy, so it would be difficult because vision is also affected, sir.
So you will do an occupational therapy.
It is a bit difficult.
So what do you understand by occupational therapy?
Occupational, it is to make sure that his day-to-day activities are taken care.
Very good. And if this child is not at a developmental status of doing any independent activity, then possibly you may not focus on other things other than physiotherapy. There is no need of any other kind of therapy in this child. So physiotherapy, yes, but not occupational therapy unless this child is able to pick up something in the hand, maybe put a spoon to the mouth. Yes, that is the time you will get on occupational therapy, but not at this time. Now, would you try a speech therapy in this child?
Speech therapy, yes, because hearing is still preserved after doing Bella. We can.
All right. So now tell me that which child of a delayed speech needs speech therapy? Every child who has a delayed speech needs speech therapy?
Sir, if the speech therapy is mainly if the cognition is preserved.
All right. So speech therapy is required only if motor part of speech, that is language, is involved.
Yes.
Language has a receptive language and an expressive language. And expressive language comes only after receptive language. If this child cannot have a receptive language because his temporal cortex is involved, his auditory functions are involved, his hearing is involved, then possibly he does not have a receptive language. In other words, expressive language is of no use to him, and he is not a candidate for speech therapy. So you can see now that not every delayed developmental child needs occupational therapy, speech therapy, etc.
Yes.
One more question. You said that this child has a hearing impairment and you will prove it thereon.
Yes, sir.
Now, would you consider any other hearing aids in this child?
Hearing aids, sir. The sensor, like if there is sensory neural hearing loss, or it is a middle ear, or is there a sensory neural hearing loss?
Good. So your answer would be if hearing is impaired because of an extracranial nerve involvement, okay, or of course the conductive loss, then that is different. But here the cortex itself is like. You said that the vision is disturbed because of cortical problem.
Yes.
Even hearing could be disturbed because of cortical problem. And if that is so, then hearing aid may not have any role at all in this child. And therefore, no hearing aid, no speech therapy, no occupational therapy. Okay. And in an examination, you don't forget to manage constipation in this child. Most of these children are often constipated. Okay,
sir. Okay, sir.
Which other drug this child will need besides managing neurology? This child needs vitamin D.
Okay, sir.
Because he will have no sunlight at all.
Yes, sir.
And if you don't give him vitamin D and he has a spasticity, his bones are going to be weak and one day there will be crack and even a fracture.
Okay, sir.
So
Okay,
don't
sir.
forget vitamin D and calcium in this child, because
Yes, sir.
he is absolutely having no vitamin D at all, and whatever vitamin D his mother had must have long back disappeared from his body. So
Okay.
imagine comorbidity is gastrointestinal GRD constipation.
Yes, sir.
Then you have nutritional, vitamin D in particular, but of
Okay.
course, general nutrition, whatever. Then
Okay, sir.
bones and joints. That's important.
Sure,
And
sir.
lastly, in a child of this nature of severe delay, there is no question of managing behavior or emotional issues. But don't
Yeah.
forget that mild or moderately delayed development children also could be autistic.
Okay, sir.
Autism often goes together.
Okay,
And
sir.
if that is so, then you may have to have sensory integration,
Okay,
all
sir.
other management for an autism.
Okay,
Autism
sir.
is a spectrum, and that is seen often in a minimally developmentally delayed children.
Okay.
So don't forget that.
Yes.
Lastly, emotional management. This
Yes.
child needs to be talked to. This child
Okay.
needs to be seeing something. We
Okay,
must
sir.
try to make that possible by any other measures, not
Okay, sir.
possible every time, but at
Okay.
least sensory integration. Let this child be handled by touch. And when
Okay.
the child is touched by the mother, the baby might feel little comfort and
Yes.
may stop crying. So
Okay.
emotional management, behavioral management are also the part of managing this child. Lastly, would
Yes.
you give an anticonvulsant to this child?
Uh,
Because this
no.
child's brain is quite damaged. He is
Yes,
at
sir.
risk of convulsion.
So, but still, there are no involuntary movements as well as seizures, sir. No positive history of any seizures or involuntary movements. So, can EEG be done? And if it is,
Very good. So you
yes,
will not give an anticonvulsant unless
yes,
there is a seizure. And if there
yes,
is a seizure,
yes,
then
sir.
in a brain damaged child, the seizure is likely to recur, and
Yes,
you might consider an anticonvulsant, but not in this child.
yes, sir.
Lastly, what is
Yes.
the prognosis of this child?
Yes, sir. It's the prognosis poor. Uh, like there'll be difficulty even in since the vision is severely affected, sir. So there could be
All right, good. You're
severe.
trying something.
Yeah.
In such a child, how will you answer a question about prognosis? One, prognosis for life first.
Okay,
Do you
sir.
think his life will be normal?
No, sir.
Why not? His higher centers are gone, but the medullary centers are working well. His heart is fine, his lung is fine, his swallowing is fine.
Yes.
He is well looked after on nutrition,
The
hygiene.
quality of life would be disturbed. The quality of life.
Very good. So you say that even the total lifespan also may not be normal, because such children are not mobile. He will
Yes.
have hypostatic pneumonia. He will have bed sores. He will
Yes.
have urinary infection and then pneumonia. So his lifespan is likely to be short, even if he is managed extremely well for his entire life.
Okay,
So
sir.
even lifespan is likely to be not what is destined normally.
Okay,
Then
sir.
quality of life.
Yeah.
How do you judge quality of life? One, will he be mobile?
No, sir. Difficult, sir. No, sir.
Why?
Unless the yes,
He has got good power.
yes, sir.
Plus
No.
3+.
Three
And tone,
plus.
you are going to see that there are no contractures. You will give
Yes, sir.
baclofen, dantrolene, diazepam. You
Yes,
will
sir.
reduce spasticity,
Yes,
reduce
sir.
tone,
Yes,
and
sir.
make him walk. Why not?
Yes, sir.
So
So
now
one.
tell me, which
Yes.
child is unlikely to walk?
Uh,
A
It
child
is
who can, a child
cannot
who
sit.
cannot sit at
It
2 years is
2 years.
never going to walk.
Okay, sir.
So you
Yes.
will say that I will prognosticate as the time goes.
Yes, sir.
In an exam, don't commit the prognosis at this point of time. You
Okay.
say that it is expected to be rather poor, but I will like to start my management and assess him further.
Yes, sir. Yes,
If I
sir.
can make him sit before the age of 2 years, I
Yes,
have a
sir.
small probability of making him stand also.
Okay,
But
sir.
I will not opine today, but I will say that in all probabilities, it is not likely to happen. All
Okay,
right.
sir.
Now,
Okay, sir.
last 5 minutes,
Yes, sir.
you do a counseling session, and I will be the parent of this child. You tell me in a layman's language what has
Yes, sir.
happened to my child.
Yes. Sir, since as you know, there was told for you, sir, as yeah, antenatally when the baby was in the womb, there has been a water collection in the brain, sir. And now since it has been delivered, and we have at 1.5 1 year 2 months of age, the development of since the baby is not able to sit or have head control, or there's I also would like it's difficult to tell you that there is a difficulty in vision also for the baby, but there could be a chance for hearing. So the both the lifespan as well as the quality of life would be impaired to a greater extent. So it is better for us to do an investigation, like likely MRI, which will give us a better insight to the abnormality in the brain, which you had detected antenatally. And depending on that, and genetic counseling, would like to refer them, would like to do a genome sequencing, sir, to rule out any the autosomal autosomal recessive genes, by doing a whole genome sequencing, and then referring him to a genesis.
All right. I will give you the correct idea. I know that these
Yes.
are not the priorities in your training right now, but they are very, very important.
Okay.
Especially once you get into practice, they are most important.
Okay, sir.
What do the parents want to know? They want to know what is the problem. They
Yes.
want to know why did this problem occur.
Yes, sir.
They want to know how are you going to manage, and they want to know what will happen after good management. They have these
Okay.
4 questions.
Okay, sir.
But remember one thing in counseling, don't give right to begin with a bad outcome,
Okay, sir.
because we want the mother to do something good for this child, at least for some time, before she realizes that that's not working.
Okay,
And
sir.
for all that you know, it might work as well. So
Okay.
the way to counsel this child is first say that I am Dr. So and so, and I
Okay.
have examined your child.
Yes, sir. Yes, sir.
And I want to inform you that unfortunately, your
Yes.
child's brain has not developed well right when the baby was in your womb.
Okay, sir.
This is the problem.
Oh,
Okay.
yes,
Why
sir.
did this occur? It is just a bad luck. It is
Yes.
nobody to blame. You are
Okay.
not responsible, nor the
Yes.
father is responsible. It is
Yes,
just
sir.
an accident, and it is just a bad luck. Nobody is responsible. Only the God knows why it happened. So
Okay, sir.
they know that they are not to be blamed for all this. That's very
Okay.
important.
Okay, sir.
Third thing, that the brain is damaged,
Yes, sir.
so your child does not understand or does not do things that a normal child can do. Now, what
Okay,
are we
sir.
going to do? Even when the damaged brain cannot be repaired, we are trying to teach this brain with whatever good part remaining
Okay,
to
sir.
try to do something good.
Okay, sir.
And that is our management.
Okay, sir.
That is not done by medicine, that
Yes.
is done by physiotherapy, which means
Okay.
that we want to make this stiff legs a little loose so that they can function well. And as the
Okay.
time goes, after 3 months of doing everything that I will explain you, you will start finding some change, at which time I will be able to tell you what further is expected. Don't say
Okay.
that oh, everything is bad. Okay, don't say that. You are right. Academically, you are right, but don't give a shock to the parent that the child is never going to improve. Give them time to digest that their child is never going to improve. They will start knowing very soon. But till then, tell them that follow me for 3 months, do all that I tell you properly, and let's assess after 3 months. I will get some idea what will be expected over further time. You get the point?
Okay,
yeah.
Sir, yes.
And at the end of a counseling session, always ask the mother, do you want to ask me any more questions? Are you clear?
Yes.
This tells you that you have shown empathy. You have shown concern. Okay.
Yes,
Which is an important part of management. Not just now to pass MD, you need to know all academics. But it's far more important than academics to make the parent feel that this doctor is trying his best and is trying to inform us everything. And that gives the parents a comfort that there is some doctor who will stand behind us to make this child better. That is very important.
Yes.
But I must end our session saying that you are a wonderful student.
Yes. Thank you.
You are wonderful. You are very good. I am told you are in the second year.
Yes.
And you will do wonderful by another year. I tried to question you in different ways. 90% of questions you could answer very well. I am sure you are ready to even appear for your MD and pass first attempt. But try to be a better doctor rather than just passing MD. I'm sure you will pass MD at first attempt. You are so good. But I've also given you last 5 minutes some more incentive to be a good doctor and not only the most intelligent doctor. Right?
Thank you so much.
Thank you very much. I hope you enjoyed the session. I enjoyed your presentation. Once again, I wish you all the best in your career.
Thank you so much. It was a great pleasure presenting for you.
Once again, thank you, White Army, for giving me this opportunity because I learn when I teach. And thank you for this opportunity.
Yes, thank you so much. So, thank you. It was indeed a comprehensive session and enlightening in terms of knowledge as well as insight for us to be future good physicians as well. And thank you, Dr. Narayan, for the presentation as well. And thank you, audience, for being with us. So, yes, we can end the session.
Just one more request.
Yes,
Any time I am asked to do a session, if there are 3-4 other students also live on the screen, then we can have a very good interaction.
Yes,
so try to get some more because Dr. Narayan was excellent in answering every question, but he was facing me very well. But if there are 3-4 other colleagues with him, it makes the interactive discussion very, very interesting. All right?
Yes,
sure.
Thank you, sir.
Thank you very much.
Good
night. Good night.
Thank you, sir. Good night.
Thank you.